This is Justine Sparrgrove, recording Learning Plan 5, Cardiovascular and Renal System, Chapters 23 and 26. So Chapter 3 is Drugs for Lipid Disorders. In this section, we're going to discuss the types of lipids, lipoproteins, LDL and HDL, which are the predictors of cardiovascular disease, lifestyle changes, and pharmacological therapy. So the types of lipids. So first there's triglycerides, which is a major storage form of fat in the body and the only lipid that is for energy source. Next is phospholipids, which are used for the building plasma membranes. And then there's steroids, specifically cholesterol is what we're mainly looking at. And this is the most widely recognized of the steroids there. We know that cholesterol is bad, and it has a bad reputation for atherosclerosis. Sorry if I can't say it correctly here. And is manufactured by the liver. So lipoproteins. So there's 3 different types of lipoproteins. And I want you to think of these lipoproteins as transporters or cars, if you will, okay? Stay with me here on the whole car thing. I don't know much about cars, but this makes sense to me. So we have the high density lipoprotein, or HDL, which you can consider your happy or your highly desirable cholesterol. So these carry the fewest amount of cholesterol. So this is the part that I want you to think about cars. So think of the high density lipoproteins as a Corvette. Everyone wants one, right? But usually we don't see a whole lot of people driving this car or in this car. It's not a large passenger vehicle, right? 1 to 2, typically. So this is an expensive or high dollar vehicle too, okay? So the H's all go together. Now we have the low density lipoprotein, or LDL, or lousy cholesterol. And this one carries the most amount of cholesterol. So think of this one as a minivan. There are a lot of them out there, and they carry a lot of people, or cholesterol, if you will. And they're cheaper or low dollar. So again, the L correlates with low dollar, H correlates with the high dollar with the Corvette, okay? And then we have the very low density lipoprotein, or VLDL, and this is known for its high amount of triglycerides that it carries. Next, we have our lipid profiles. So our total cholesterol less than 200 is considered desirable. Greater than 240 is high risk. Our LDLs, or our low dollar or lousy cholesterol, however you want to look at it, is if it's less than 100, that's considered desirable or optimal. And if it's greater than 160, you're considered high risk. Then we have our HDL, or happy, or highly desirable, or high dollar, however, again, you want to think of it. Cholesterol, if that's less than 40 for men and 50 for women, you're considered low risk. And if it's greater than 60, it's considered desirable. So this is the one that we want the higher numbers on, because we want more of them. And then there's the triglycerides. So less than 150 is considered desirable or normal, and greater than 200 is considered high risk. All right, so lifestyle changes. First, we want to make some lifestyle changes, if at all possible, before having our clients take any medications. So what are some lifestyle changes that you can make to lower your cholesterol? So labs, so monitoring blood lipid levels regularly as recommended by a physician can help do that. Weight, so maintaining your weight at an optimal level. Exercise, implement medically supervised exercise plans. So no going rogue with exercises. Diet, reduce dietary saturated fats and cholesterol, so eating better. Fiber, increasing that soluble fiber in the diet, such as oats, bran, apples, beans, grapefruit, and broccoli. But beware that with grapefruit, it can actually decrease the effectiveness of certain cardiac medications or enhance them, such as antiarrhythmics. So some medications it'll enhance, some of them it'll decrease. And then tobacco, which we want to reduce or eliminate the tobacco use. Next, the HMG-CoA reductase inhibitors, or statins. They're the first-line drugs in treating lipid disorders. Note that they all have a statin in them. Okay, so after a statin, as you can see, they all have statin at the end. So the mechanism of action here. So they act by inhibiting the HMG-CoA reductase, which results in less cholesterol biosynthesis. In other words, it stops the liver from making cholesterol. Okay, the body then kind of freaks out and says, I need, the LDL cholesterol, and starts making more LDL receptors on the liver. This then pulls the cholesterol out of the blood. But this, isn't permanent, and it only occurs while the patient's actually on this medication. So then if they go off it, then the receptors dissipate and the cholesterol enters the blood once again, creating the lipid disorder. So this is something that they would have to pretty much take the whole rest of their lives. Our common ones here are the atorvastatin, pravastatin, lovastatin, rovastatin, and simvastatin. So again, your statins are your key thing there to help you pick out which drugs are the reductase inhibitors. So some statin teaching. So the severe side effects include the myopathy and rhabdomyolysis, okay? And make sure the patient knows that they should be taking them at night, because that's when the biosynthesis is higher. So they get more for the buck, basically, more bang for the buck. Bile acid resins, they bind bile acids, leading to excretion of the cholesterol in the stool. So the body responds by increasing the amount of LDL receptors on the liver, which removes even more cholesterol. So common ones that we see here, cholestyramine, cholestyvalum, and cholestypol. I can say that correctly. So it looks like they all have OLES in them, as something maybe you can use to help pick that out as well. And up here under resins, this also has ES, as it has ES here. So maybe that's something that'll help you out here. They may be used in combination with other drugs. They cause more side effects than the statins. So, most commonly GI bloating and constipation. And they have a drug-on-drug interaction with warfarin and digoxin, minerals, and vitamins. Niacin. Niacin, or niaspan, is a B-complex vitamin. Its primary effect is to decrease the VLDL levels, thus decreasing the LDL levels, because those go hand in hand. And they do those in combination. So this is usually taken with something else, not taken by itself. Common side effect for this is flushing, hot flashes, GI upset. Serious adverse effects include hepatotoxicity and gout. It's contraindicated with patients that have diabetes because it can actually increase the blood sugars or blood glucose, and should only be taken under medical supervision. So they do have over-the-counter niacin, but you don't want to tell people to just start taking them. And then they take whatever dose they feel is going to help decrease their cholesterol, because that's not truly why it's over the counter at that point. I did give you a year-old puppy dog down here because he's having hot flashes, and it was really cute, so I had to add it. Fibric acid agents. So they're replaced by the statins, but can be used in combination with statins. They're the drug of choice for treating extremely high triglyceride levels. Side effects are related to the GI system, which usually means one needs to eat with it. And it's contraindicated for patients with hepatic impairment or gallbladder disease. Are common ones that we see here, the fenofibrate and the gemfibrozole. Our miscellaneous drugs section is the cholesterol absorption inhibitors. So that's going to be like the Zetia. So the mechanism of action here blocks the absorption of cholesterol in the intestinal lumen. And unfortunately, the body then responds by making more cholesterol. So it's recommended that statin be given in conjunction with this. So they work together. Another one is fish oil or omega-3 fatty acids. And then this one is usually contraindicated in a person with allergic reaction to seafood, just because it is a fish oil. So it kind of makes sense. Moving on, chapter 26, drugs for hypertension. So in this section, we're going to focus on the definition of hypertension, factors responsible for hypertension, physiological regulation of hypertension, non-pharmacological management of hypertension, and the pharmacological management. So hypertension, HTN for short, is the consistent elevation of systemic arterial blood pressure, so high blood pressure, right? The diagnosis is not made after just one high reading when you go to the doctor. Usually the physician will send you home with a log and have you take your blood pressure at specific times of the day for multiple days. And then they'll look at that consistency. So when you come back in, they'll have you bring that logbook in and they'll sit down and look at that. They just want to make sure that it's not something that's what's happening when you come into the doctor's office is the white coat syndrome, where basically your blood pressure is higher when you're in the hospital or clinic setting just because you're nervous. Who doesn't go to the doctor and it seems a little nervous, right? Obviously, unless you work there, like nurses or healthcare providers, but they just want to rule out that white coat syndrome. Hypertension does affect approximately 1 in 3 Americans, and African Americans have the highest rate of hypertension. And for adults over the age of 65, hypertension is more frequent in women. So let's look at the classification of hypertension in adults. Normal blood pressure reading, 120 over 80, right? Pre-hypertension is considered systolic, 120 over to 139, and then the diastolic, 80 to 89. And stage 1 hypertension is 140 to 159 systolic, and 90 to 99 for diastolic. And stage 2 hypertension is the greater than 160 systolic, and the greater than 100 diastolic. So factors responsible for blood pressure. So these are 3 main factors that influence blood pressure. So blood volume is the total amount of blood in the vascular system, which is approximately 5 liters. So there's fluid loss or dehydration, which will cause blood pressure to drop, along with medications such as diuretics, which will cause the fluid loss, leading to the decreased blood pressure. Then there's the fluid retention due to aldosterone or antidiuretic hormone, or ADH. That is the extra fluid that will increase the pressure in the arteries, which in turn then increases the blood pressure. The next section is peripheral resistance or diameter of arterioles, which can impact the blood pressure as well. So the sympathetic nervous system is activated, and then this will increase the blood pressure. And then renin-angiotensin II system is in your kidneys, and this can also increase your blood pressure. And then the increase in blood viscosity will also increase that blood pressure. And this final section here is cardiac output. So that is the volume of blood pumped per minute. So the higher the cardiac output, the higher the blood pressure. So the stroke volume, preload, contractility, and afterload all play an important part. And then the heart rate is due to the sympathetic and parasympathetic system and or the epinephrine that could be given. Okay. All right, so this figure here is the physiological regulation of blood pressure. So it basically shows how your body provides the homeostasis during your blood pressure changes, so what your body does as a mechanism. So if your blood pressure increases, excuse me, if your blood pressure increases, the compensatory action by cardiovascular system, it includes the vasodilation to decrease the blood pressure, decreases stroke volume, and decreases the heart rate, and then in turn the cardiac output decreases and returns the blood pressure to normal. Otherwise, the compensatory action for the kidneys or by the kidneys increases your urine output, which then decreases the blood volume, and the blood pressure then will return to normal. Okay, so here's our ABCD again that we talked about back in Learning Plan 4. So the sympathetic nervous system stimulates alpha-1 adrenergic receptors causing the vasoconstriction. So again, that's the A to C. And then the beta-2 adrenergic receptors cause dilation, specifically in the lungs. And so that's the section B to D there. But at this point in time, right now at the moment, the B to D isn't relevant. But make sure you keep that in the back of your mind because this will come in handy. Real soon. I was going to say later on, but it's sooner rather than later, actually. So etiology and pathogenesis. So primary hypertension, there's no identifiable cause as to what's causing it. It just kind of is. Secondary hypertension, there's an identifiable cause, such as Cushing's syndrome, hyperthyroidism, renal disease, and some medications can cause it. And usually we want to take care of whatever's causing it to help get rid of that hypertension. And then there are 4 target organs that are usually affected: the heart, brain, kidney, and retina. So the heart usually ends up having to work harder to pump the blood. The brain, you can have some brain damage to the blood vessels, and then that can cause a stroke. With the kidneys, the damage to the arteries cause decreased renal function. And with the retina, the vessels in the retina can rupture or become occluded, resulting in visual impairments or blindness. So the non-pharmacological management of hypertension. So to decrease or eliminate the hypertension altogether, we want to limit the intake of alcohol, restrict the salt consumption, because salt holds fluid and fluids increase blood pressure. We want to reduce the intake of saturated fats and cholesterol, because this can lead to the plaque buildup in the arteries, which then leads to the constriction and then the increased difficulty of the blood flow and increases the blood pressure. And then we want to discontinue the use of tobacco products. And we also want to increase the consumption of fresh fruits and vegetables, increase aerobic physical activity, increase stress management, and then maintain our optimal weight. So primary antihypertensives. So we have 5 main categories of antihypertensives. So there are diuretics, angiotensin converting enzymes or ACE inhibitors, angiotensin II receptor blockers, calcium channel blockers, and adrenergic antagonists. Specifically, our main ones here are our beta blockers. So starting out, so our diuretics. Our diuretics increase the urine output and decrease the fluid volume, thus decreasing the blood pressure. They have a few side effects. And the diuretics are utilized for hypertension. And the main ones here are your potassium-sparing agents. So they leave the potassium in the body and only cause modest voiding or diuresis. And that's usually the spirolactone and triamterene. Then we have the thiazide and thiazide-like agents. Those deplete the body of potassium through voiding. And note these end in thiazide, so those should be a little bit easier to pick out. And those common ones there are the hydrochlorothiazide and the chlorothiazide. And then we have the loop or high ceiling agents. So they deplete the body of potassium through major voiding and cause the highest risk for dehydration and ototoxicity. And our common ones here are the lumantadine, the furosemide, and torsemide. So when giving these drugs, you may need to know what the patient's potassium level is. So potassium-sparing agents can cause hyperkalemia, while the thiazide and the loops can cause hypokalemia. So what's a normal potassium level? So you're going to see a little bit of variations. It depends on where you go, what labs are drawing it, because they all have a little bit of their own specific range. But 3.5 to 5 or 3.5 to 5.3, the flip, is kind of the general area that you will see being used. And again, you're always going to have to be looking at those potassium levels when you're giving your diuretics, because your potassium levels could either be too high with your potassium sparing, or they could be too low with your ones that actually deplete the body of potassium. Next, we have ACE inhibitors, or PRILs. So they all end in PRIL, P-R-I-L. So something that may help you is think of the month of April, PRIL, right? Our blood pressure decreases because our taxes are done. Yay! And maybe we'll be getting some money back. Or another way to think of it, if you're not getting money back, unfortunately, that the flowers are starting to bloom, and this could be potentially a stress reliever, right? Winter's coming to an end, and we're moving on into April where it starts to get warmer. So ACE inhibitors block the formation of angiotensin 1 to angiotensin 2. And angiotensin 2 is the major vasoconstrictor. And then it can block the aldosterone secretion, which is the main action of that, is to increase the sodium. And then we know wherever sodium goes, water goes, right? This blocking causes vasodilation, thus lowering peripheral resistance and decreasing blood or fluid volume. So the adverse effects are not commonly severe, but do include a cough, headache, dizziness, orthostatic hypotension, rash, chest pain, nausea, vomiting, and diarrhea. Hyperkalemia or high potassium may occur during therapy, and rarely angioedema does occur, but like I said, it's rare, but it is a serious side effect that could happen. So a way to remember this, as far as side effects, you give them an ACE and they'll cough in your face. Okay, so ACE, face. Again, it's a very common side effect, and it's it's actually the most common side effect, and it's usually severe enough that the physician will actually stop the drug and give the patient or person a different classification of med. So a lot of times, if someone's got that dry, nagging cough that just doesn't seem to go away, you ask them, hey, are you on an ACE inhibitor? Because ACE in your face. Our most common ones here, benzapril, captopril, enalapril, and lisinopril. Angiotensin II receptor blockers, or ARBs, ARBS. They're also known as sartan sisters. So they all have sartan in them, and they work at angiotensin II. And so there's two sisters is how I kind of think of it. So sartan sisters, they work at angiotensin II. So they kind of go together. So that helps me remember. Oh yeah, they work at angiotensin II because they're sartan sisters. There's two of them, or at least 1 and 2. So how this works, it prevents the angiotensin II from breaching its receptors. So basically angiotensin 1 has already converted into the angiotensin 2. So if you didn't prevent angiotensin 1 from converting into angiotensin 2, which again constricts the vessels, you could use an angiotensin 2 receptor blocker to prevent the angiotensin 2 from reaching its receptor sites, causing that vasodilation. So candesartan, irbesartan, losartan, and valsartan are your common ones. Calcium channel blockers, CCBs, are pines or penes. A lot of times I say pines, but when I pronounce it, I say penes. And they're selective for blood vessels. Okay. And they end in pines. So the way I remember it is, if you could see me, I'd get down on one knee and I'd say, I pine for calcium. The calcium channel blockers pine for that calcium. Okay. The contraction of muscles is regulated by the amount of calcium and ion inside the cell. So when we block the calcium ion channels, it limits the muscle contraction by relaxing the arterial smooth muscle and then lowering the peripheral resistance. They work either by selectively affecting blood vessels or by affecting both blood vessels and the heart. So the calcium channel blockers are usually not used as a monotherapy, so as a single therapy for chronic hypertension. They are, however, useful in treating certain populations, such as the elderly and African Americans, who are sometimes less responsive to drugs and the other antihypertensive classes. So in this section, we assess for signs of CHF and reflex tachycardia, as some calcium channel blockers actually reduce the myocardial contractility. With IV administration, tachycardia and hypertension, this is more pronounced. We want to make sure that we assess for pregnancy, because they are a pregnancy category C. And then we assess for dizziness, headaches, and flushing. These are all minor side effects. As a nurse, we should be teaching the patient to avoid drinking grapefruit juice. There that grapefruit juice is again, because it actually increases the absorption of these drugs. And then obviously they'll end up decreasing your blood pressure even further. So this could be amlodipine or amlodipine, felodipine, nicardipine, and nifedipine. So non-selective calcium channel blockers, they work on both the blood vessels and the heart. So again, they're not selective for one or the other. And these do not end in pine, but they're just as effective and they're just not as selective, but they do have multiple uses. So these two are diltiazem and verapamil. And last but certainly not least are beta blockers that end in LOL. So our LOLs. They used to be the first line of drugs, but now they're not considered to be used first line. They decrease the heart rate and myocardial contractility, and they reduce the cardiac output and lower the blood pressure. It has few adverse effects because it selectively targets beta 1 receptors located in the heart. But the adverse effects that occur are slowing of the heart rate and hypotension, abnormal sexual dysfunction, drowsiness, fatigue, and insomnia, and even bronchoconstriction. Okay. So our common ones here: atenolol, metoprolol, propranolol, and timolol. There are a few other sections here, but these are, again, the most common ones that we'll see. So remember, there is section 2 for Learning Plan 5, so don't forget to listen to that when that comes up for you. Have a good rest of your day or evening or night.